The Grasshopper and the Ants. One bright day in late autumn, a family of ants was bustling about in the warm sunshine, drying out the grain they had stored up during the summer, when a starving grasshopper, his fiddle under his arm, came up and humbly begged for a bite to eat. "What?" cried the ants in surprise. "Haven't you stored away anything for the winter? What in the world were you doing all last summer?" "I didn't have time to store up any food," whined the grasshopper. "I was so busy making music that before I knew it, the summer was gone." The ants shrugged their shoulders in disgust. "Making music, were you?" they cried. "Very well. Now dance." And they turned their backs on the grasshopper and went on with their work. The lesson Aesop wanted us to learn: there's a time for work and a time for play. My interpretation and message for you: you don't have to get ready if you stay ready.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. We can all be like the grasshopper. We got it. We learned this once. We'll be fine if the need arises. But we never know when we'll have to deal with a precipitous delivery and the initial steps in neonatal resuscitation. Do you feel that prepared that you can take on 2 potentially critically ill or decompensating patients at once? You may have some help, but you need to delegate. Or you may be the one that everyone is looking to. How do you lead? What do you need to know? And more so, what do you need to be able to communicate to the team for success? Our post-pandemic world has affected the whole healthcare system. We're seeing less prenatal care and more delays to presentation, which means more precipitous deliveries. In fact, multiple studies on different continents have documented the same phenomenon. In addition to incomplete prenatal care, other risk factors for precipitous delivery include teenage pregnancies and substance abuse. We have to be ready in the ED to help mom and catch baby, but also to prevent mother from hemorrhaging and to resuscitate the infant who needs it. Today we'll talk about precipitous delivery, immediate care, and maneuvers that you can do if there's a complication in the ED, as well as expectant management. In the next episode of the Playbook, we'll review neonatal resuscitation. If the mother delivered at home or in the car or in the parking lot, by the way, sometimes we have teenagers check in with abdominal pain only to deliver in the toilet or in the pediatric emergency department. So no fiddling for you. Time to get ready. If the mother has delivered, it's IV O2 monitored, just as you know. Ideally, another team is helping the baby, but that may be you as well. There may be some back and forth here while you help mom look at the baby. Okay, let's just assume the baby is like 90% of newborns and just needs to be warmed, dried, and stimulated. Back to mother. The first and second stages of labor have already happened. The first is the long process of contractions and cervical dilation, and the second is delivery of the baby. The third stage is where we find ourselves now between delivery of the baby and delivery of the placenta. At this point, if the baby hasn't required intervention, you may wait 60 seconds, then clamp the cord. Place the baby securely on mom's chest. Now, you may think that you're in good shape, but you can't relax now. What you do in stage 3 of labor can markedly decrease the risk of severe postpartum hemorrhage and the need for blood transfusion. 3 things that you can do to help. 1, uterine massage. 2, very gentle tension on the umbilical cord. And 3, uterotonic medication as needed. To perform uterine massage, place your dominant hand flat on the mother's abdomen just at the uterine fundus. Apply careful but firm pressure in a continuous circular motion. The intention is to stimulate the uterus to contract, so expect waves of discomfort as you massage, but keep going. Make sure that your level of pressure is sustained and constant throughout. Make sure not to bounce on the fundus. Be nice to the uterus. Slow, gentle, and firm, continuous. This is the most efficient and best tolerated method. Cord traction. Gently keep the cord taut and directed down. The cord should be comfortably taut. Think more straightened out rather than pulling on it. You don't want that cord to separate from the placenta. Here's a pro tip, the Brandt-Andrews maneuver. One hand secures the uterine fundus on the abdomen. Basically, you're using your hand to grasp the fundus to prevent uterine inversion. This should be your non-dominant hand. So for me, I'm grasping the fundus with my left hand. The other hand exerts sustained downward, gentle traction on that clamp that you just placed on the umbilical cord. Can you picture it in your mind? One hand cups the fundus, the other gently rests on the clamp that you had just placed. Slow, steady, patient. If you're thoughtful and cautious with the Brandt-Andrews maneuver, you can reduce the need for manual placental removal. Gallos et al. In the New England Journal of Medicine reported a statistically significant reduction in the duration of the 3rd stage of labor, of blood loss, and the incidence of postpartum hemorrhage. The same authors found that the use of a bundle treatment, so that's uterine massage, Brandt-Andrews, oxytocin, and TXA when needed, was associated with less postpartum hemorrhage, need for laparotomy, and less mortality. During this process, you're going to want to add a uterotonic agent. The first choice is oxytocin. Now, oxytocin is an amazing natural chemical. You're a secretor. I'm a secretor. We all secrete oxytocin. It's the feel-good hormone. The hypothalamus stimulates the posterior pituitary lobe and releases it into circulation. In labor, cervical pressure initiates a feed-forward reflex to stimulate oxytocin release. When we give it IV, we are enhancing the natural process. This is a safety mechanism for us in the hospital to decrease the risk of severe postpartum hemorrhage. It's basically more cowbell. In this case, oxytocin is doing double duty. It causes uterine contractions and it decreases maternal stress, anxiety, and even pain. Remember, it's the feel-good hormone. We started at 1 to 2 milli-international units per minute and can increase every 15 minutes slowly up to 20 milli-international units per minute. When the OBs give oxytocin during the 2nd stage of routine labor, the only downside is that there could be fetal heart decelerations and even sometimes tachycardia. After birth, obviously that's no longer an issue, so we can give it in the ED to promote uterine contraction and prevent hemorrhage, and you can titrate the oxytocin even more quickly. As the uterus continues to contract and deliver the placenta, you'll see a gush of blood. That is the placenta separating from the uterus. It's a good sign. Keep massaging that fundus. Small, firm, circular movements at the apex of the uterus will help the smooth muscle contract further and lessen bleeding. Okay, the placenta is delivered. Find yourself a Mayo stand, turn over the placenta, invert it. Look for missing pieces. Okay, stay with me here. Remember, the first 2 stages of labor, cervical dilation, delivery of the baby, all of that was about keeping the baby safe. The 3rd stage of labor, delivering the placenta and preventing postpartum hemorrhage, all of that is about keeping mom safe. Now is the time to look. You can relay this important piece of information to the obstetricians. Now remember that the placenta is a mysterious sea creature. It seemingly migrates. It can be attached too superficially or too deeply. It can deliver in whole or in part. The truth is, once the placenta is formed, it doesn't actually move, but its relationship with the cervix can change, and it really should change as the uterus expands. A low-lying placenta in the third trimester can complicate a routine vaginal delivery. If the placental villi adhere to the uterine myometrium without invading the decidua, this is placenta accreta. If the villi invade the myometrium, this is called placenta increta. If the placental tendrils penetrate into the uterine serosal outer layer and even into other organs like the bladder, this is placenta percreta. Now, how in the increta are we supposed to know? We need to recognize the possibility of retained placenta, because not doing so now may mean ongoing hemorrhage or even the need for surgery. If placental tissue is left in the uterus, it will release large amounts of tissue factor, which triggers a systemic cascade of coagulation, resulting in widespread clot formation and ultimately paradoxical bleeding because of the depletion of clotting factors and platelets throughout the body. Precipitous deliveries are even more precarious because we're making big decisions with very little information. But then again, that is our jam. All right, that was all fun and games, and as the saying goes, vivieron felices y comieron perdices. They lived happily ever after and ate partridges. If you know, you know, I guess. Well, my little partridge in a parturition tree, what if the mother is crowning? The baby doesn't progress. You can't put mom and baby in an elevator and just hope for the best. Or maybe help is on the way, or help is in another hospital. What do you do when you have a complication with stage 2 of precipitous delivery, delivery of the baby? Let's go over what to do with a nuchal cord, a prolapsed cord, shoulder dystocia, and breech deliveries. The nuchal cord. The umbilical cord is wrapped around the baby's neck. You'll notice it after the delivery of the head. So if you're doing gentle perineal stretching and massage during delivery, as you should, you can help prevent labial tears, but in this way you can also more efficiently detect a nuchal cord. You're gently sweeping around the baby's head and you feel a rubbery cord. What do you do now? You have to deal with it. The baby cannot be safely delivered with a nuchal cord, and no one at this point is moving that baby out of your department. So, call for an extra set of hands. Get 2 Kelly clamps and a pair of scissors available to you in case you need them. Now, here is the decision that you have to make. Is the nuchal cord loose or tight? If you can get your fingers between the cord and the head, try to see if it may be loose enough to gently pull up and over the head. When I say up and over, I mean sliding the cord from posterior to anterior and then cephalad to mom. So basically up and over towards mom's umbilicus. This would be the best case scenario. Now remember to manipulate the cord in very short spurts. During delivery of the baby, you don't hold that umbilical cord in a position of tension for more than a few seconds because you can impede blood flow. Sweep the head, feel if there's some space. If the cord feels relatively loose, up and over. If you can barely get a finger between the cord and the head, or it just won't go up and over, then you're forced to clamp and cut cautiously. This is why you have everything on hand to make this snap decision. Gently place 2 Kelly clamps on either side of where you're going to cut. Careful not to hurt the baby's neck. My advice? If you clamp it, you should be the one to cut it. I mean, you should place the clamps where you want them, then get someone else to hold those clamps so that you're the one to cut. You know the anatomy best since you're right there. You clamp, you give the clamps to someone else to support them, and then you cut. Once you cut that cord, that baby needs to get out. Be prepared to have to resuscitate, as the child may not have his first breath for a moment, and now his oxygenation and ventilation are gone. You just cut the cord. In summary, sweep the head after it's delivered. Feel for a cord. If it's loose, up and over. If it's tight, clamp, clamp, cut. Cautiously, and get that babe delivered. Okay, what if you see a purple snake bobbing up and down on the baby's head during delivery? That is a prolapsed cord. You may think, hey, at least it's not around the neck. That should be okay, right? No. The garden hose of life is kinked at both sides now. Less is more by you. If you see a prolapsed cord, the mantra is, do not push, you or the mother. Stop the oxytocin. Tell mom to breathe through her contractions and do not push. You need to elevate the baby's head off the cord. The cord, it should be plethoric, purple, and not white. Keep that baby's head off the cord and do not stop until everyone and his mother is in the OR, prepped, draped, anesthetized, and then you can let everyone else be and get the obstetrician to perform the C-section. Prolapse cord is no joke. Shoulder dystocia. Not many things scare me anymore in the ED because either we can only make them better if they come in extremis, or we know how to handle something, at least start the treatment, do what we can, try to manage the situation. Shoulder dystocia doesn't feel the same way for me. Although we didn't cause the baby's shoulder to get stuck, we are witnessing a terrible thing in slow motion. Mendez-Figueroa et al. In the American Journal of Obstetrics and Gynecology did a secondary analysis of the data from the Consortium of Safe Labor, an observational cohort of 19 hospitals over 7 years, which included more than 228,000 women. Maternal morbidity was 14%, mostly due to trauma. Neonatal morbidity was 12.2% with shoulder dystocia, compared to 2.4% without. Babies can develop asphyxia, or they can have clavicular or humeral fractures. They can get brachial plexus injury or even death. What can we do? Well, there are several named maneuvers that have been shown to help deliver that anterior shoulder. Once the presenting shoulder is delivered, typically the baby can be safely delivered. The first maneuver makes gravity work for us. Put the head of the bed down, rails up, and have mother go on all fours. You can deliver the child with gravity helping you. The McRoberts maneuver is hip hyperflexion. It's used almost instinctively in most routine spontaneous vaginal deliveries now because it aligns the sacral symphysis axis with the route of exit for the baby. So it's just easier for that route of passage if the hips are hyperflexed. Have one helper on each side pull the mom's knees up and to her sides. This will change the exit angle and make delivery of the anterior shoulder more possible. You can amplify the benefit of McRoberts' hip hyperflexion by having another person apply gentle suprapubic pressure. This helps the anterior shoulder disengage from the location where it's stuck behind the symphysis pubis. There are more complicated maneuvers that the OBGYNs will do, but just 2 more that are straightforward for us. The Rubin 1 is actually suprapubic pressure used with the McRoberts maneuver that we just talked about. But the Rubin 2 entails inserting your dominant hand into the vagina behind the baby's shoulder and rotating the shoulder to the baby's chest. This may help to dislodge the shoulder from behind the symphysis. You can progress further by adding the Woods screw maneuver. So Rubin 2 has you sweep the anterior shoulder to the chest, while the Woods has you sweep the posterior shoulder to the back. So now you're twisting the baby in both sides with the Woods. This twists the baby so that his head faces the mother's rectum. You're just changing the axis of the child's torso so that now it's 90 degrees from where it started, and hopefully off the symphysis. The Zavanelli maneuver is a rare last-ditch effort in preparation for a C-section. It doesn't take much finesse. You push the head back into the canal while the OBGYNs prep for the cesarean. It's not common and it's not without complications, including tissue damage to the mother and potential postpartum infection. If you truly have no backup and no C-section is happening anytime sooner, remember, if you stay ready, you don't have to get ready. You can perform another procedure that may save the child. You can perform a symphysiotomy. A what? A symphysiotomy. You can cut and release the cartilage at the symphysis to open the pelvic rim and allow for delivery in shoulder dystocia. How, may you ask? Well, with lots of consent first. You place a Foley catheter, which will serve as a safety buffer between your scalpel and the baby's head when you cut, and also will help you to move the urethra out of the way. You anesthetize with local infiltration of lidocaine to the suprapubic area very generously. You infiltrate the skin and subcutaneous tissues, superior, anterior, and inferior to the symphysis along the midline down to the cartilage. Infiltrate also where you're likely going to do an episiotomy. Now, let me preface this with saying that what may seem barbaric and unnecessary when an OBGYN is present may be life-saving for the baby in breech or with shoulder dystocia when no one else is around. It's very unlikely that we have to do this nowadays in a hospital setting, or really in any developed country with ready access to care. I just mention it now because if the universe conspires to prevent you from ever needing to do it, here it is. Ward off evil spirits. Remember to use iodine and chlorhexidine and sterile technique. With the index and middle fingers of the hand inserted into the vagina, push the urethra to the side. Don't cut the urethra. Place the index finger in the groove formed by the cartilage between the 2 pubic bones in a way that you can feel the scalpel's movements as you're cutting. The catheterized urethra has to be pushed out of the way. So the Foley is helping you to direct that urethra out of your scalpel's direction. Locate the upper edge of the symphysis and bring the scalpel down about 1 centimeter below that. You're going perpendicular to skin, exactly on the midline. Cut down until you get to the cartilage. It should feel elastic. If it feels bony, gently withdraw the blade and recheck your position, only through the cartilage. First, tilt the blade toward the top using small back and forth motions, always on the midline, in a way that you get about 2/3 of the cartilage through to the upper edge of the symphysis, going slightly past it. Then you turn the blade around towards the bottom and basically are cutting from the bottom up now. You're repeating that sectioning maneuver down to the lower edge. The procedure is complete when the pubic bones give. They move apart. The assistants continue to hold apart the thighs. Remember the McRoberts maneuver, making sure that they keep that pelvis more or less stable, right? You don't want them to go too far apart. Brace everybody, tell them what you're doing. Once you widen the symphysis, it shouldn't really exceed more than 2 to 2.5 centimeters, so about the width of your thumb, just enough to be able to deliver that anterior shoulder. You can always follow up with an episiotomy if you need to. So you need lots of hands on deck. You at least need one person per knee, somebody to do the symphysiotomy, which is you, and then also someone now to help deliver the baby. There's multiple people involved here. Lots of trauma involved here, but if the delivery can be successful, we can avoid brain anoxia or death of the baby, and the mother will do better with controlled surgical trauma than prolonged crushing injury and potential sepsis. Our last precipitous scenario, the breech delivery. The baby can be a complete breech if the buttocks are the presenting part and both knees are bent. An incomplete breech is when only one of the knees is bent. A frank breech is when the buttocks are the presenting part, but both legs are straight up towards the face. Frank breech is the most common type of breech that we see, and luckily the most responsive to our maneuvers. This is a happier scenario, I promise. Okay, the mantra for the breech is, hands off the breech. Luckily, babies are like little al dente rigatoni. They are floppity and flexible. The child may grow up even to be a Pilates star. We'll have to just see about that. The buttocks present and they're delivered, right? So butt first, still hands off. Remember our mantra. What is it? Hands off the breech. Let the little bucatino bend the buttocks down that specified route. Wait some more for the umbilicus. Once the umbilicus is delivered, now you get to work. First, flex and sweep the baby's legs. One little leg, boom. Two little leg, boom. And then wait some more. Hands off. Some techniques will actually have you let the baby dangle. Now, I'm not into that based on how many breeches I've delivered on my own, so I just mentioned that our mantra stands, hands off the breech, and gravity is your friend. At this point, you can wrap the torso in cloth surgical drapes so that you can control the body better. Remember, babies are slippery. Support the body. Wait for the scapulae now. Once you see scapulae, and it's just similar to the legs with the arms, you flex and sweep each arm. One flex, two flex, one out, two out, and then you gently rotate the shoulders out. Now it's just the head and neck. You're supporting the torso with one hand on the back and the other hand cradling, supporting, and anticipating the delivery of the face. The baby will likely be occiput anterior so that the face is already downward. So control the maxilla. You may even have to depress the face and jaw a little bit into his airway so that the face clears posteriorly. But it's not a big deal because baby's not using his airway anyway. You can go ahead and smash that little face in so that you're able to clear. Now, move your hands so that now one is holding the legs and one is supporting the face and the head, right? Deliver the child down and then elevate the feet up to the ceiling. And voila! Breech delivered. Down and up. Precipitous deliveries may happen at any time. Mothers are not typically moved when there's active delivery. That means they stay with us in the ED. That's great if there's an OB in your pocket. If not, we have to be ready. Now, I know I got a little intense there with you just now with all of the things that we may be called to do. But I did that because I love you. And I want you and your big and little patients to love you too. Review these in your mind from time to time. Next time when you see that teen girl with very baggy clothes who is screaming in pain, just think, you don't have to get ready if you stay ready. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.